Afternoon. Thanks, Dr. Umesh Khanna, sir, for giving me an opportunity to present on this August forum. So, transplantation with abnormal bladder in 10 minutes with cases. I'll do my best. Principles of management, it's no longer a contraindication to renal transplant. So allograft outcomes of various studies nationally and internationally are similar. Slightly higher incidence of UTI, especially if the clean intermittent catheterization is not done properly. The goals of management is to ensure the safe urinary tract, address the bladder issue prior to transplant, keep them free from infections, and try to establish continence. So these are the list which all of us are aware. Where do we see bladder dysfunction? Not going into the details. So the International Continence Society has divided voiding dysfunction into the following types. Overactive bladder, where there's a filling phase defect. Dysfunctional voiding phase defect. Underactive bladder, giggle incontinence, and detrusor sphincter dyssynergia. So basically what we should try to understand in the clinical is what we encounter as a spectrum of both. Sometimes it can be a mixture. The overactive bladder will eventually die out to be an underactive bladder. The underactive bladder has loss of bladder contractility, is seen in elderly patients and late stages of overactive bladder, whereas the overactive bladder or a hostile bladder is more dangerous, common in younger patients associated with hydronephrosis, again lead on to CKD. So as I told you, the underactive bladder or the lazy bladder. So the urodynamic shows a typical large capacity bladder with low detrusor pressures, low pressure despite high volume filling, and there is poor emptying and diminished uroflow. So how do we how do you manage the underactive bladder? The upper tracts are usually preserved, so that's a big plus point for us. Basically, we need effective bladder emptying, scheduled voiding, double voiding, clean intermittent self-catheterization, and you have incontinent and continent drainage. This has been emphasized by Dr. Nivedita in her lecture about clean intermittent self-catheterization. The lack of education post-transplant of the parents and the children, we have to encourage them to do it to have a long-term improvement in the graft outcome, and it should be done in the sterile technique. CISC per se has not been linked to increased incidence of UTI. It's only if done improperly with a break in the sterile precautions. So we all are quite familiar about this Mitrofanoff procedure, where it creates a continent low pressure reservoir for external drainage through the skin. And normally, traditionally, the appendix is used. There have been a lot of case reports of fallopian tubes, the native ureter being used, and let's see what we used in our patients. So as I said, these are the various urinary diversion procedures which are available. Let me not go into the details as it is self-explanatory. What is dangerous, as I mentioned, is the hostile bladder, where there is bladder overactivity, impaired compliance, and there is a leak point pressure of more than 40 centimeter water, DSD, associated with secondary VUR and incomplete bladder emptying. In the urodynamic, you can see that there is an increase in the detrusor pressure and the abdominal pressure. Concomitantly, you have the EMG, or the pelvic, that is the external urethral sphincter contracting these solid arrows, and this represents DSD, detrusor sphincter dyssynergia, associated with hydrouretronephrosis. So the goals in overactive bladder is give anticholinergic medications. Botulinum injection has been tried in various case reports, and we should always consider to surgically enlarge the bladder. So how do we enlarge the bladder? As we all know, it's bladder augmentation, urinary diversion procedures. A very young child who presents after birth, we do a vesicostomy and sphincterotomy. Moving on to our experience, we have done 9 pediatric transplants in our unit from the last 6 years. 5 of them had vesico-aortic reflex and an abnormal bladder. The rest were all bilateral small kidneys with CKD with no hydronephrosis or bladder dysfunction. So this was a boy, he had posterior urethral valve, which was diagnosed antenatally with hydrouretronephrosis. There was intrauterine vesicoamniostomy was done, and there was valve fulguration, which was done 3 days later after his birth. He was lost to follow-up, and the doctors outside did not educate them, and he voided normally. But he had nocturnal enuresis till 6 years, as all parents think that this is normal, and they did not bring the child to the doctors later. At 4 years of age, someone had advised him to get an MCU done that showed an altered bladder shape with trabeculation and diverticuli with grade 4 to 5 VUR. and there was a significant post-void residue of 35 ml. Don't know why he was not advised CISE or no corrective surgery was done, but the doctor there had given deflux gel, and then he said it will be all right. As you grow up, the reflux will go off. So there was no breakthrough UTI in this patient, but he was fully evaluated. He did have a DTPA which showed CKD, reduced functioning kidneys both sides, ultrasound, there was gross hydronephrosis on the left side with parenchymal thinning, and right kidney was also showed altered CMD. So he came to us when he was 7 years of age. He did have some mild uremic symptoms, and he was counseled for transplant. So the pre-transplant, we had evaluated him, and the urodynamic study, which showed now surprisingly a normal capacity bladder, filling pressures normal, but he had a very poor flow. So MCU was done at 7 years. Now there was no reflux, and the renal transplant was done at 7 years of age. He was 18 kg. It was a preemptive transplant. All our pediatric transplants were preemptive. We did not have a single pediatric transplant taken up for dialysis. So the father was the donor. The mother had diabetes, so the father was the donor. This patient, we decided to do the left nephrectomy to avoid risk of pyelonephritis after transplant, as it was grossly hydronephrotic. And we had decided to do a left native ureter Mitrofenov. The patient had no induction was given, normal post-operative transplant course, normal renal function. Initially voided through the Mitrofenov. That is, he was doing CIC, then voided normally with nil PVR over the next 1 year, and he's not using the Mitrofenov anymore. He voids normally per urethral. So we had a midline incision in this. So post-transplant, the child never had UTI. Probably the bladder urodynamics were normal, but it was poor flow. Probably it was not a contracting bladder, but it was never it was not an overactive bladder causing upward changes or graft changes. It was an underactive bladder which required CIC temporarily. Post-transplant, uroflow was normal after 4 weeks. There was post-void residue was nil. He was on temporary clean intermittent self-catheterization and later off CIC. So the unique features in our patient was we used the native ureter Mitrofenov. It's always better than the appendix because there's no new anastomosis which is needed. And we have a natural urothelium which is already there, so it becomes easy for adaptation. This patient had a midline incision, and we had to anastomose the renal artery to the common iliac artery and the renal vein to the IVC. There are reports of 40 to 50% of urinary leak after using the native ureter for Mitrofenov, but our patient did not have any urine leak. There are very few case reports published on the use of a native ureter Mitrofenov. I'm sure other people would have had various experiences, but I could find only 1 or 2 on the PubMed. Most cases used appendix or colon as the conduit. There are rare reports of the native ureter being for Mitrofenov procedure. As I mentioned, there's no new anastomosis. It can be done only if there is a bladder capacity which is normal, and if at all you have to do an abnormal overactive bladder, the bladder has to be reconstructed. So this is, we do have permission, so he was presented in the public and all, and this is how the, sorry. This was post-op day 2. He's enjoying. Doesn't seem that the surgery is done also. A very cooperative child and very happy. And at the end of 2 years after transplant, we did organize a World Kidney Day program when we felicitated our pediatric transplants. That's the father and the son. The second case is another PUV, diagnosed 2 months of birth, no antenatal diagnosis. He underwent a valve fulguration and vesicostomy in 2003, and later there was a closure of the vesicostomy after 6 months. The patient had a left cutaneous ureterostomy due to a pyonephrosis on the left side for 3 years, and then the pouch closure was done. The urodynamics was a small capacity hostile bladder. This patient did have an augmentation cystoplasty with an appendicular Mitrofenov in 2006. He was voiding normally per urethral and through CISE 4 times a day and at night. He did have CKD from 2015, hypertension, recurrent urinary tract infection. The bladder had evolved. What was initially a hyperactive bladder, by the time he came to us 5 years later, was an poorly contractile bladder. So, and we had to do a transplant to him. Just before the transplant, the MCU showed no vesico-ureteric reflux, and there was significant PVR, possibly due to hypocontractile bladder. There was, this was the Uroflow recording from the urodynamic study, and it showed dysfunctional voiding. Either the patient had a lot of cough or raised intra-abdominal pressure, or he had some feature like a staccato flow or a dysfunctional voiding. So he underwent a live-related renal transplant at 15 years. Donor was his father. Mother had diabetes. Haplomatch, 3% cross-match negative, no induction. Ischemia time 1 hour 10 minutes, slightly more due to double artery. The main artery was anastomosed to the recipient internal iliac, and the accessory artery was anastomosed to the inferior epigastric artery. He received the standard triple immunosuppression, normal graft function. Initial output was more in the Foley's through the Mitrofanov than the urethra. Later he voided normally, but he had multiple episodes of urinary tract infections, graft pyelonephritis, requiring antibiotics up to colistin. So he was put on antibiotic prophylaxis. We had changed mycophenolate mofetil to azathioprine. He did have, on a repeat urological evaluation, a post-void residue was 150 ml. Underactive bladder. He is on CISE 3 times a day and 1 time at night. So this is the patient. You can see the stoma on the left side and the bladder incision on the right side. Follow-up of our pediatric transplant patients. Only one patient had a recurrent graft pyelonephritis. He was not on regular CISE after proper counseling, and he was on regular CISE, and graft function became normal. All the other 5 patients are doing well. Serum creatinine settled at 1.3 after multiple episodes of pyelonephritis for the above case. But the other 2 are less than 1 with no breakthrough UTI. Thank you.
Thank you very much.